Great. Good morning, everyone, and thank you for joining us, both online and in person, for our talk today, which is Loosening the Grip of Hypertrophic Cardiomyopathy, Updated Strategies for Timely Diagnosis and Treatment. Here is a QR code for any of those that are joining in person and virtually. I'm Lakdawala Owens from the University of Pennsylvania, and I'm joined today by my colleague, Dr. Neil Lakdawala from Brigham and Women's Hospital. Here are some slides and practice aids that you can access after the talk. And our goals today are to sharpen your skills on suspicion of HCM, diagnosis of HCM, and we'll talk about new therapies that are available for this condition. Before we begin, we have a few questions that you can use your iPads to answer. The first is to please select your specialty. Great, and we'll move on to please select your degree. And next, in the past month, how many of your patients had an abnormal EKG, systolic heart murmur, unexplained syncope, stroke, and/or family history of unexpected sudden death, heart failure, or stroke? This is a hard one to ballpark at 6 o'clock in the morning, but do your best. Okay. And which of the following practice settings is applicable to you? All right. So before we begin, a question. In which sex is HCM associated with a worse prognosis? The choices are listed below. All right, and which of the following is a defining hemodynamic criteria for obstructive HCM?
Anjali, I like the music you've selected for these questions.
Very upbeat.
Yeah.
Makes you want to dance, which we're not going to do. The next question, what is the most important consideration in selecting an alternative to septal reduction therapy, or SRT, for patients with obstructive HCM? How about this one?
I think you're going to dance, yeah.
See if it'll let me advance there. Okay, let's get started. So the first segment will be about heightening your awareness and the rationale for increasing suspicion of HCM. So with a little bit of epidemiology to start, we know from worldwide studies that the prevalence of HCM ranges somewhere between 1 in 200 to 1 in 500 individuals. Again, this is worldwide, affecting men and women equally, and people of all ages can have HCM. With those estimates, we think that there are 15 to 20 million people living with HCM worldwide. Many of these patients are undiagnosed, partially diagnosed, or diagnosed late. So not everyone that's living with HCM knows it. The causes of left ventricular hypertrophy in many cases is HCM, and within that group, in 40 to 60%, we can identify a pathogenic variant in a sarcomere gene, which is listed on the left of the slide. But in the other cases, 25 to 30%, it's either unknown or perhaps a polygenic risk that we're learning more about in terms of how to classify patients and understand that genetic risk. And in another 5 to 10% of patients, they have left ventricular hypertrophy that may look like HCM, but it's actually something else. And that's where our infiltrative or storage diseases, diseases such as amyloid, and other syndromic causes may lay. So I would encourage you in your clinics as a first thing is that when you see left ventricular hypertrophy, don't stop there. Look further for the cause of left ventricular hypertrophy, and in many cases you'll be able to diagnose HCM or perhaps another condition that has a targeted therapy. When we do diagnose genetic HCM, we know it's the result usually of a sarcomere variant. And so pictured here as a schematic of the sarcomere, and you can see the vast majority of pathogenic variants are in myosin heavy chain and in myosin binding protein C. We'll talk a little bit about the underlying pathophysiology of HCM and what we think is happening with too many cross bridges forming between actin and myosin, leading to hypercontractility and left ventricular hypertrophy. And we'll talk towards the end of the talk about how our newer therapies target this underlying pathophysiology. So what we see in a clinic as a result of sarcomere variants is over time, adverse neurohormonal signaling that leads to diastolic dysfunction, in some cases outflow tract obstruction. We get adverse remodeling of the left ventricle with hypertrophy, with fibrosis, resulting in arrhythmias, and of course our most feared complication, sudden cardiac death or heart failure symptoms. Here's the hemodynamic classification that we typically use. And again, think of this as somewhat arbitrary, as a continuum of patients that are non-obstructive, which we define as an LVOT gradient that is less than 30 millimeters of mercury. There are two subtypes that you can see there with an apical variant and then a more septal predominant variant. In the middle, we have pictured the obstructive hemodynamic subset where you get a gradient greater than 30. And again, you can see the more classic phenotype with LV outflow tract obstruction, and pictured there is systolic anterior motion of the mitral valve here. And then we have a mid-cavitary obstructive phenotype, which is pictured in the middle. With this phenotype over time, you can get formation of the left ventricular apical aneurysm. And then finally, we have what we call the latent or provocable obstructive phenotype, where your gradient is less than 30 at rest, but with Valsalva or exercise, you can provoke obstruction. We know that HCM is associated with significant excess mortality. This occurs across the age spectrum. Patients who are diagnosed early in life with clinical HCM do have a worse prognosis in terms of having complications of death, heart failure, and significant arrhythmia. But even in the older ages, we do see excess mortality. When we look at phenotypic expression by sex, we can see some differences between women and men. This gets back to one of those pretest questions, but we generally see women present in a more advanced stage of disease. They are older at the time of diagnosis. They're more symptomatic with more diastolic dysfunction, and more heart failure. Now, the reasons for this are not entirely clear, but we do wonder if perhaps our somewhat arbitrary cutoff of 1.5 centimeters of maximal end diastolic wall thickness may have something to do with this. Women tend to be smaller body size, and perhaps a thickness of 1.5 is already signifying significant hypertrophy in those smaller individuals. We also think that women's symptoms as reported are perhaps misconstrued or attributed to other causes, including anxiety and other things, and that healthcare professionals are less likely to consider HCM until further along in the disease course. We also look at conflicting data with regard to African American or Black patients versus white patients with HCM, and there are some studies in the literature that report no differences or few differences, and there are other studies that report more basilar hypertrophy, more apical aneurysms, and the genetic cause of HCM in our African American or Black individuals is not well elucidated because of the lack of inclusion of those individuals in our large genotype databases. So we need to do much better than we are in terms of getting our African American or Black patients into clinical studies and into our clinics, our specialty clinics, to be seen. So we've made some headway over the past few decades in terms of improving mortality by use of defibrillators to reduce the incidence of sudden cardiac death. We have widespread use of echo in many places, at least in the US, which is helping with earlier diagnosis. But we have a little ways to go, and particularly in the realm of septal reduction therapy, we know that that's a specialty procedure that's not widely available, and so depending on your socioeconomic status or your geographic status, you may not have access to high-volume centers or specialty HCM centers, and we hope that some of the newer therapeutic options may allow patients to access new care. So let's start here with a polling question. You'll recall this one from the beginning. In which sex is HCM associated with a worse prognosis? How about this music? It's a little more
Soothing.
A little more soothing.
Yeah. Nothing says increased mortality like piano music.
Okay, yes, great. So females have a worse prognosis. We went through that with the slides, and actually one of Dr. Lakdawala's studies that he published. Let's move to the next segment, which will be Dr. Lakdawala talking about the differential diagnosis of HCM.
Thank you, Dr. Owens. So many of us know how to think about hypertrophic cardiomyopathy when a patient comes to us in clinic and with a big stack of notes and a diagnosis of HCM, but at the front line, sometimes it's more ambiguous. And it's nice to step back and think broadly how patients with hypertrophic cardiomyopathy often first present. So their symptoms can fit with just about any cardiovascular syndrome with exertional dyspnea, dizziness, syncope, angina, and palpitations as prominent symptoms. And maybe one of the early tip-offs that HCM is underlying this or the variability in their symptoms dependent on day-to-day factors, meals, ambient temperature. Careful family history is often a tip-off to an underlying diagnosis of HCM. We know that, like most inherited cardiomyopathies, it's inherited in an autosomal dominant fashion. So when we put together our careful family tree and identify male-to-male transmission without skip generations, that would make the case, but not always so obvious. Sometimes those family histories are notable for deaths which are unexplained and require a little more digging to understand what drove them, or it could include premature stroke or even heart failure and transplant. On exam, we of course listen for a murmur and we try to augment or manipulate loading conditions to bring out what is classic in hypertrophic cardiomyopathy. So with the Valsalva maneuver or other maneuvers that will decrease preload will often accentuate the murmur of HCM. If we're looking at patients to tell us how they feel before they were diagnosed with HCM, they'll tell us that dyspnea is the most common symptom. This comes from the Hypertrophic Cardiomyopathy Association, a patient advocacy organization that polled their patients. Exercise or effort intolerance is prominent along with dizziness, palpitations, and chest discomfort. We're working as a community to try to better measure the symptom burden of hypertrophic cardiomyopathy, and much like the KCCQ has helped to inform quality of life metrics in heart failure writ large, there are disease-specific quality of life metrics being developed for HCM, and one is listed here with domains separated by the types of symptoms, dyspnea, fatigue, broader cardiovascular symptoms. And again, recognize that their symptoms can vary based on day-to-day factors, the temperature, when they've eaten, whether they've had anything to drink, or maybe all of the above. What do our guidelines tell us? Well, our guidelines tell us the same thing. Look for the same symptoms, the family history, listen for a murmur, look for an abnormal ECG or echocardiogram. And once we're there, the basic clinical evaluation should include a careful 3-generation family tree, of course, a complete exam, 12-lead ECG, an echo with provocative maneuvers. So this is where you want your sonographers to be good at getting multiple perspectives of the outflow tract at rest and with Valsalva. An exercise echo, especially if there are symptoms of exertional dyspnea, to assess for latent obstruction, as Dr. Owens had mentioned, and a cardiac MRI, if available, when measures of wall thickness and cardiac morphology may not be as well captured with 2D echo. Genetic testing plays an important role, especially in understanding who in the family is at risk, and may add to our understanding of global prognostic awareness. What about just the EKG? Can we make do with a simple 12-lead ECG as a screening test? We look for left ventricular hypertrophy, repolarization abnormalities, Q waves. But it turns out that just as a screening test, the 12-lead ECG falls short. So this is data that comes from the Johns Hopkins HCM clinic. And the most common ECG abnormality was some form of repolarization abnormality. Altogether, about 2/3 of patients had a repolarization abnormality, T-wave inversions or ST segment depressions. This was followed by left atrial enlargement, and then our classic LVH criteria that we learned about in medical school. And importantly, almost 20% of these patients had a normal ECG. So a 12-lead ECG is not enough. Patients need cardiac imaging if we suspect HCM. Does echo do enough? I think in many patients, echo does a great job at characterizing left ventricular remodeling, but there are patients who have suboptimal windows where the value that cardiac MRI provides can be crucial for making a diagnosis. So one is how much hypertrophy. We know that the magnitude of hypertrophy plays an important role in our understanding of sudden death risk. And here is a representative 2D still where we measure the septal thickness at 21 millimeters. And then on the bottom panel, there's a patient who has left atrial and to a lesser extent right atrial enlargement, but nothing apparent in the left ventricle, largely because of acoustic windows. But with cardiac MRI in both cases, we can see that management is impacted by better fidelity images. So in the top panel, a better measure of wall thickness, which can have prognostic ramifications. And in the bottom panel, where 2D echo poorly characterized the LV apex, we got a good picture from cardiac MRI. Some of this, of course, can be overcome by using echo contrast. So another polling question. So you answered this earlier. Which of the following is a defining hemodynamic criterion for obstructive HCM? And I hope we can cue the music. So we had a LVOT gradient greater than 30 at rest. We had, I think people picked that, but then they also picked greater than 30 at rest or greater than 50 with exercise. Fortunately, very few people picked greater than 20. So 30 millimeters mercury is that inflection point that we like to use to diagnose obstructive physiology in HCM. So what can trip us up? How can we overlook a diagnosis of hypertrophic cardiomyopathy? Some of it is a diagnosis that is carried forward or clinical inertia. So a patient comes to you and says they have exercise-induced asthma. There's nothing to see here, but of course, this is a classic diagnosis in younger people who have obstructive HCM where you have not done the proper imaging to make a diagnosis. Mitral valve prolapse can cause a systolic murmur. Another pitfall in hypertrophic cardiomyopathy, occasionally the murmur is dismissed as not being associated with pathophysiology, and that's where you want to have a good assessment of cardiac remodeling, and cardiac MRI may be useful. Patients may not ever get to see a cardiovascular specialist and have their symptoms attributed to superintentorial factors. And then, perhaps most alarming, patients who've had syncopal episodes may have this attributed to a neurocardiogenic mechanism or a vagal episode. There are other causes of left ventricular hypertrophy that we need to consider when evaluating a patient for suspected hypertrophic cardiomyopathy. One is very common. Amyloidosis, I think, as a community, we've learned to appreciate in large part because of the prognostic and therapeutic ramifications. And then a number of either storage or phenocopies are listed here. Broadly, one general tip-off, but not always the differentiating factor, is that these are usually a cause of concentric hypertrophy. And with the exception of amyloidosis, several of them are associated with pre-excitation on a 12-lead ECG. So a pseudo-delta wave can be a sign of a metabolic cardiomyopathy like Fabry, PRKG2, or Danon disease. And several syndromic conditions have other extracardiac features like neuropathy, CNS factors, and even some skin findings. So we'll shift to a case. This is Alan. He's a 43-year-old man who presents to you for exertional dyspnea. He has had fatigue in conjunction with this, a couple episodes of exertional lightheadedness, and you categorize him as having functional class 3 impairment. His blood pressure was 110/70, heart rate was 55, and you had arranged genetic testing based on the echocardiogram I'm about to show you, which was negative for a sarcomere variant. And here is his 12-lead ECG. Here are some representative 2D images, one with color Doppler. On the left panel, we can see preserved left ventricular systolic function. The septal wall thickness is increased. There is systolic anterior motion of the anterior mitral leaflet. And on the right panel, there's some left atrial enlargement. Again, hyperdynamic, or at least preserved systolic function with septal thickness, and flow acceleration in both the mitral coaptation point and towards the outflow tract. So Doppler images taken from the same patient in a 3-chamber view at the left ventricular outflow tract show that there is flow acceleration associated with a pressure gradient at rest of almost 50 and with Valsalva 86 millimeters mercury. So what is Alan's diagnosis? So given what I've shown you, his history, his ECG, and the imaging studies, what do we think is most likely? Do we think this is Danon disease, one of those metabolic cardiomyopathies? It's an X-linked disorder caused by LAMP2 variant. Is it hypertensive cardiomyopathy? Is it obstructive HCM, or is it mitral valve prolapse with regurgitation? Are we just not sure? Do we need more data?
This one's new. Giving us some variety.
Yeah. So great, obstructive HCM, you're here. Everyone's had some coffee, so.
Next time we're doing a Danon case, that's it.
Yeah, that's it. So, agreed. All right, so what do we do? So surgical approaches to managing hypertrophic cardiomyopathy. This is our tried and true, has been a therapeutic option for decades now. So according to the guidelines last published in 2020, here are our consensus recommendations for when surgery is useful for a patient with hypertrophic cardiomyopathy. And you'll see, in general, these are all second-line options. So first-line therapy for a person with preserved systolic function and non-obstructive HCM. We still have our old standbys of beta blockers and then L-type calcium channel blockers. How well they work is I think, a valid question. For people with systolic dysfunction, this is a high-risk patient population, HCM patients who no longer have a hyperdynamic ventricle. We should use guideline-directed medical therapy as we would for any patient with HFrEF if they had been on a calcium channel blocker or disopyramide because previously they had outflow tract obstruction. Those drugs should be stopped. And this is a high-risk patient population that the guidelines have now advocated be strongly considered for a defibrillator. For obstructive HCM, first-line therapy or non-vasodilating beta blockers or L-type calcium channel blockers, we should avoid things that'll cause our patients to become to have a low preload, so high-dose diuretics, for instance, and vasodilators. Surgery slots in as second line for each one of these. For the rare patient who has preserved systolic function, profound diastolic dysfunction, and associated heart failure, sometimes we do offer transplant in that patient. For patients with LV systolic dysfunction, if CRT or resynchronization therapy is considered in patients who have a wide QRS and a left bundle, and again, heart transplant, and this is really where transplant is used most frequently in HCM. And then, of course, what we're here to talk about, obstructive hypertrophic cardiomyopathy, septal reduction therapies in patients who fail first-line medical therapy. But when we look at a large cohort of patients with hypertrophic cardiomyopathy from the SHARE registry, now nearly 10,000 patients strong, about 1/5 of the patients at that macro level need septal reduction therapy. So this is a big number of people. Maybe not the most common outcome in the lifetime of a patient with HCM, but up there, just behind needing a defibrillator or having atrial fibrillation. Our two options at a cartoon level are a septal myectomy and an alcohol septal ablation, and our surgical colleagues will make an aortic incision on bypass and through the aortic valve resect the proximal interventricular septum, shown on the left of the panel. And alcohol septal ablation requires suitable coronary anatomy. We need a large first septal perforator. We need to make sure it doesn't subtend anything else important so we can infarct it without causing untoward or unexpected damage. And I have here an algorithm for when we would consider septal reduction therapy. And I think the most important thing I'd emphasize is that it's important that your operator has done this before, that they have experience doing septal reduction therapy. And so when we decide between alcohol septal ablation and septal myectomy, that's probably our first question. But if all things are equal, if the patient otherwise needs surgery for either coronary artery disease or mitral valve disease that's not from SAM, then surgery is going to be your choice. Often patients will vote for alcohol septal ablation to avoid midline sternotomy and the typical recovery from surgery. And then there are some iterations to the plan that, especially in high-risk patients, where we can use some of our newer less invasive approaches like a MitraClip or PCI in patients in a hybrid approach. I think this is a new take and a new way of representing something we've known for a long time, that for these specialty operations, we want our patients to have them done at a center where they've done more than a few. So these are data looking at the hazard ratio associated with septal myectomy as a factor of how many procedures are done at that institution, and we can see that there's a steady downward trajectory in risk as you have your procedure done in a center that's done more. There are some selection and ascertainment biases here for sure, but we do need operator experience. Earlier on, Dr. Owens had touched on some of the disparities in medicine as they relate to hypertrophic cardiomyopathy. And at a macro level in septal reduction therapies, we've learned that patients who have obstructive HCM are more likely to have a septal myectomy if they're treated at a teaching hospital. If they're Hispanic, they're much less likely, or if they're non-white, much less likely to receive septal myectomy for outflow tract obstruction, and maybe it associated with increased risk. And same is true for women. So we talked about closing the gaps in treatment of hypertrophic cardiomyopathy, and I think one of the important outstanding ones is ensuring that patients be afforded best practice when it comes to managing obstructive HCM. In this case, it may mean septal myectomy or alcohol septal ablation at a highly experienced center. And from this perspective, some of our novel therapies or newer options may close the gap by offering an equal playing field to patients regardless of where they are. So one more question. What is the most important consideration in selecting an alternative to septal reduction therapy for patients with obstructive HCM? Is it their responsiveness to GDMT or guideline-directed therapies? Is it the magnitude of hypertrophy? Is it the presence of coronary artery disease? Is it the patient's fitness for surgery? Is it the surgeon's experience in performing SRT? Or is it none of the above? Great, and I think this is what we were looking for. If we're going to refer a patient for septal myectomy, we want to know that our surgical colleagues have done this before. Dr. Owens.
Thank you. So we will go through a little bit of clinical trial data, talking about new therapies for HCM. We're starting with the first-in-class cardiac myosin inhibitor, mavacamten, which was FDA approved in April of 2022 for the treatment of adults with symptomatic class 2-3 heart failure from obstructive HCM to improve functional capacity and symptoms. So we'll go through a little bit of data about this drug. And the way that it works is by reducing hypercontractility. So you take a heart with HCM, which is typically hypercontractile, and at the sarcomere level, you'll remember that I showed a sarcomere, and what we think causes a hypercontractility is excessive actin-myosin crossbridge formation. And this drug reversibly inhibits some of those cross bridges, thus reducing or modulating left ventricular contractility. This is the VALOR HCM crossover trial. So the original VALOR HCM 16-week data was presented by Dr. Desai just a year ago at ACC. And those patients that were randomized to placebo for the first 16 weeks then had the opportunity to cross over into active treatment for the second 16 weeks. So this is 32-week data from the VALOR trial. And what we saw in the original mavacamten group, which is listed at the bottom on the left, again, 100% of these patients were eligible and under consideration for septal reduction therapy. So this was a sicker group of patients. Over 90% were class 3. They were all eligible for SRT. In the original mavacamten group, by week 16, only 18% were still eligible for SRT, whereas in the placebo group, 77% remained eligible for SRT or decided to undergo SRT. So in the crossover trial, what we saw is that when patients started mavacamten, so again, this was the placebo group up until week 16. Then they crossed over to mavacamten, and you can see by week 32, they met up with their colleagues who started on mavacamten from the beginning with pretty substantial reductions in resting and Valsalva LVOT gradients. The magnitude of reduction was similar to what we saw in the pivotal phase 3 trial, the Explorer trial. Here is data also in that 32-week group looking at placebo in green, crossing over to mavacamten at the 16-week crossover point, and we saw an expected small drop in left ventricular ejection fraction in the range of about 4 to 5% in patients who were treated with mavacamten. And again, this is because of the mechanism of action of reducing hypercontractility. Looking at markers of diastolic function, we saw that there was a reduction in the septal E prime ratio. And again, once patients crossed over and got active drug treatment, they met their colleagues who started off on mavacamten with significant reductions in E over E prime. When we look at NYHA class, which is somewhat crude and interestingly does not always correspond with gradients in our patients with HCM, we did nonetheless see an improvement in NYHA class in the group of patients who were on mavacamten versus placebo, and you can see that listed here. And again, the group at 32 weeks who started off on mavacamten, so this is the group at 16 weeks, started off on mavacamten, 63% had an improvement or greater than equal to 1 functional class. By 32 weeks, we're up to 91%, so they had additional further benefit by being on mavacamten for another 16 weeks. And the placebo to mavacamten group was similar to where the initial group was at that 16-week mark, suggesting that 16 weeks is good to show a benefit, but perhaps longer-term therapy will give us additional benefits. Certainly, we're not seeing that it plateaus or goes away. We're seeing sustained benefit through those 32 weeks. So there will be additional data presented today by Dr. Desai. This will be the KCCQ data. This is coming this morning, so be sure to tune in for that, showing the improvement in KCCQ for patients who were in VALOR and that 16-week endpoint. There is a lot more data coming from the Explorer-HCM trial, and again, that's the pivotal phase 3 trial that led to the FDA approval of mavacamten. Dr. Wang from Duke will be presenting 2 presentations in subgroups of the Explorer trial, and Dr. Kreshe from WashU will be presenting 2 more sets of data, again, in subgroups from the Explorer trial, so be sure to tune into those. Dr. Saberi and Dr. Masri will be presenting additional long-term efficacy data. Dr. Saberi will be presenting on MRI data, and again, this is very interesting, 96-week data on MRIs. We're all very interested to see what is going to be the long-term effect of remodeling in the patients who are on mavacamten for this many years. And Dr. Masri will be presenting even longer-term data. So these were the true pioneers, the Pioneer OLE study, which was the phase 2 study. Those patients, some of them have been on mavacamten now for 4+ years. So this is the longest-term data that we have. And my own colleague from Penn, Dr. Riza, will be presenting some real-world data that we've gathered at our institution since FDA approval, so tune into those. Next, let's talk about the next-in-class agent. This is aficamten, again, a cardiac myosin inhibitor, a reversible inhibitor of cardiac myosin. This drug has a shorter half-life, so we do titrate it more quickly because you can reach steady state quicker, and I'll show you some data about clinical trials in aficamten. So the first is the Redwood HCM trial. This was very recently published now data. And this is a phase 2 study. The design was a randomized trial, aficamten versus placebo. All patients were on background standard of care therapy, which was either beta blockers or calcium channel blockers. All patients were symptomatic with severe obstructive HCM. This was a dose-finding study. The doses are listed at the bottom with cohort 1, including lower doses, and cohort 2 with the higher doses. Looking at the change in gradients, again, both resting and Valsalva gradients, you can see a dose-dependent, really remarkable reduction in gradient that started as early as 2 weeks in the aficamten cohort 1 and cohort 2 versus placebo. And again, a similar nice reduction that's sustained that we saw in the Valsalva gradient. Now, at week 10, that was the end of treatment for this study, and then there was a 2-week washout. And importantly, we like to see that the gradients went back up to baseline. So this is a reversible drug, both aficamten and mavacamten. Here's the LVEF effect with aficamten, and again, by mechanism of action, we expect a small drop in ejection fraction. This is the way the drug works. So as cardiologists, we have to get used to modulating contractility in these patients and understanding what those small drops mean. Importantly, no one dropped below the threshold of dose reduction, which was set here at 50% in our patients with HCM. Here is some data both on hemodynamic response, which is on the left, and also NYH response. So these are 2 responder analyses that were done in the Redwood study, and you can see a dose-dependent improvement in hemodynamic response. And we defined a complete hemodynamic response in this study as a resting gradient below 30, which you'll recall is our definition of obstruction, and a Valsalva or provocable gradient less than 50. And in the higher dose aficamten cohort 2, a remarkable 93% of patients reached that hemodynamic response threshold. I'll call your attention to aficamten cohort 3. This is an open label cohort, which included patients who were on AV nodal blocker and disopyramide. So this was the first study of disopyramide with aficamten in conjunction. This was a much sicker group of patients, as you might imagine, who were refractory to disopyramide plus AV nodal blocker. These are very hard patients to treat if they don't want septal reduction therapy. And in that group, we did see a response, but not quite as a robust response. This cohort was mainly done for safety, so the higher dose of aficamten was not utilized in this cohort 3, but it will be looked at in the ongoing Sequoia HCM study. You can see an NYHA response, again, very similar to what we see with mavacamten, with over 60% of patients reporting an improvement of greater than or equal to 1 class. Now, aficamten cohort 3, again, open label, and we know there's quite an effect from NYHA on open label, so I would just take that with a grain of salt. There are 2 poster presentations or moderated posters that are being presented on aficamten here at ACC. So again, I encourage you to tune in to these. Dr. Saberi, who's busy this meeting, will be presenting long-term data on aficamten in patients with obstructive HCM. And Dr. Masri, also very busy, will be presenting new data on non-obstructive HCM. So again, this is a nice population to think about. This is going to be the next horizon in terms of cardiac myosin inhibitor therapy. So this should be very interesting data. So as clinicians, where do cardiac myosin inhibitors now fit into the management of our patients with obstructive HCM? So if you look at our first-line therapies, and Dr. Lakdawala walked you through what the guidelines say in terms of what to do with our patients who have symptomatic obstructive HCM, the mavacamten Explorer data would suggest that if you have a patient either on a beta blocker or a calcium blocker, they remain 1, symptomatic, 2, with a high gradient, that you can add in mavacamten as add-on therapy, as was done in the Explorer trial, with significant benefit. In terms of the second-line therapies, or patients that are sicker, there we're looking at whether or not patients want to go septal reduction therapy, whether they're candidates anatomically to undergo septal reduction therapy. Many of those patients are offered disopyramide as second-line therapy. And based on the VALOR data, we have phase 3 data from VALOR showing that addition of mavacamten on top of optimized medical therapy can provide additional benefit in terms of gradient reduction, symptom improvement, and patient-reported symptom improvement. So what do you need to know about mavacamten? Mavacamten was approved by the FDA with a REMS program, so risk evaluation and mitigation. We expect that the ejection fraction will drop by a bit in many patients who are treated with mavacamten. And again, that drop is around the order of 4%, but of course will vary by patient. And you don't want to initiate mavacamten in anyone whose left ventricular ejection fraction is less than 55%. And again, that gives you a margin to have a little bit of reduction of contractility and still not get into any sort of issue with systolic dysfunction. This is also important, is that if your LVEF drops to less than 50% at any point when treated with a cardiac myosin inhibitor, you need to temporarily interrupt therapy, allow that ejection fraction to return to the above 50% range, and these hearts will return to their baseline if given enough time, and then you can restart the therapy at a lower dose. Another very important point about mavacamten, there are significant drug-drug interactions that need to be taken into account. So at every point that you're seeing a patient who's on mavacamten, you need to run through their med list and check to see that there are no new prescriptions or over-the-counter meds that they are taking that may have an interaction. And we encourage all of our patients to let us know and let the specialty pharmacy know if they're starting any new therapy. The REMS program includes a training for prescribers, for pharmacists, and you really cannot prescribe or dispense this drug without going through the REMS training, at least at this point. So let's look at the incidence of left ventricular ejection fraction less than 50% reported in the phase 2 and 3 trials. And you can see here the non-obstructive HCM population, which is the MAVERICK population. This is a little bit of a different bear, and I think we're going to have to think carefully about how we utilize cardiac myosin myosin inhibitors. There will be trials coming looking at this on the phase 3 level. This was a phase 2 study. And in this dose-finding study where they were pushing to PK levels, we did see up to 12.5% of patients have a temporary reduction in LVEF to less than 50%. In the obstructed population, much less so. And again, you can see the data listed here. So back to our case, and then we'll take some questions. A 43-year-old man that Dr. Lakdawala presented, Alan, who was feeling very fatigued, dyspneic, having exertional presyncope, which again is a worrisome sign in an obstructed HCM patient, class 3 by history, blood pressure normal. He had a resting bradycardia because he's on metoprolol at very high dose, and he had no causative genetic variant identified on genetic testing. And again, this was a trick question that Dr. Lakdawala gave you, but this is still obstructive HCM. Even with a negative genetic testing panel, we know that we do not pick up all causes of HCM on our current genetic testing panels. So here is his echo images again. You'll remember he's got systolic anterior motion of his mitral valve. That's part of the mechanism by which we're seeing LV outflow tract obstruction. With that, Sam, you're seeing flow acceleration in the LVOT, posteriorly directed sort of eccentric mitral regurgitation, which is typical of SAM-related MR. He's got a dilated left atrium, a thick septum, and as we typically see, a normal to hyperdynamic ejection fraction. So what are the therapeutic options for this patient? What would you do for him in terms of treatment? His resting gradient is 47, his Valsalva gradient is 86. And I think I'm going to ask you what to do. Let's see here. Given the medical history, EKG, and imaging studies that you've seen, what regimen would you now recommend? He's a young man on very high-dose beta blocker with a resting bradycardia, ongoing class 3 symptoms. Add diso, add a loop diuretic, add mavacamten, refer for myectomy. We're not sure. We're at the end now. We got the jazzy music.
Yeah.
All right, let's see what people said, and then we'll see what Dr. Lakdawala said. So most people, 74%, would add mavacamten. Few people would add disopyramide. And 19% would refer for myectomy. So let's see what Dr. Lakdawala would do.
I think this is a great example of how we can tailor our therapies to our patients' wishes and their other extenuating factors. So disopyramide has been around for a long time. I think the efficacy is okay, not been demonstrated in the same rigorous fashion as we would like. Drug is not always available. There's some important side effects. He does not have a prohibitive QT interval, so it would be reasonable, especially in the past, if he didn't want surgery. I think this would have been an easy slam dunk for SRT, a patient with class 3 symptoms in spite of max dose beta blocker in the past, but now with myosin inhibitors. And based on your conversation with the patient and their wishes, I think a mavacamten option would be entirely reasonable as well. That's my feeling.
So, this young man is a police officer in Philadelphia, and he was not keen on taking a medication for the rest of his life daily, so he actually opted to undergo surgery, septal myectomy. He's done very, very well, fortunately with no complications, and is back to work and feeling great. Excellent. So that was his decision in this case, and I think that's probably it. So we're happy to take some questions. There may be questions online, and also certainly from the room. Yes.
I have a couple of questions. In the original study, when you were looking at gradients, were the echocardiography readers blinded to the treatment, versus placebo group? That's one question.
Yeah, so the EchoCore lab was blinded to treatment assignment. All they had was a study ID, in fact. So the study physician, the patients, and the EchoCore lab was blinded to treatment assignment. Okay.
And then the second thing is, do you have things that you can tell us about MRI findings, pre and post? Thank you.
So in the Explorer pivotal phase 3 study of mavacamten for patients with mostly class 2 obstructive HCM, there's a subset who underwent MRI before and after. And then, as Dr. Owens mentioned, Dr. Saberi will be presenting even longer-term MRI data. So we know from the first half that there is a modest reduction in LV mass, in the magnitude of maximal hypertrophy, and perhaps most encouraging, a reduction in left atrial size. So left atrial volume index is also reduced with mavacamten therapy. The longer-term data would suggest that improvement stabilizes. So it's not that year over year over year we're seeing further reduction in LV mass. There was a very low burden of late gadolinium enhancement in the subject populations in this study to understand how this impacts that form of cardiac damage picked up on cardiac MRI. But that's still an evolution in the long-term extension data.
Thank you for this talk. Do you have any information about prospect of pediatric teenagers for mavacamten?
Yes, I think both companies that are making cardiac myosin inhibitors are interested in doing pediatric trials, so I think we'll see those coming soon.
Every once in a while, I'll see a patient with a combination of valvular and subvalvular obstruction. Now, not severe AS, maybe mild, moderate AS, and then some component of subvalvular obstruction. How do you handle, diagnose, treat someone like that?
Great question. Often a conundrum that we see too. I'm interested to see what Neil thinks. At Penn, we do a heart team approach, so we do get our surgeons, our interventional cardiologists involved. And often we are doing concomitant AVR and myectomy if the degree of AS is severe enough. In a case where the AS is not as severe, I would say that we are now tempted to use cardiac myosin inhibitors in select cases where there's definite SAM, and we think the predominant mechanism of obstruction is the dynamic component, as long as there is less than moderate or to severe AS. But I think, it's got to give it some thought, I think. What would you do?
I totally agree. A clinical conundrum, and I'd restrict that to the patients with mild aortic stenosis, where maybe you're not so sure what the magnitude of the gradient is, but you're not as worried that this is a patient with symptomatic valvular stenosis, because I worry about the risk of precipitating heart failure in that patient population because they need their contractility. And those are people who are excluded from the clinical trial, so we can't really rely on our clinical trial data to guide us.
Yes.
Thank you for the excellent talk. I just have a question regarding aficamten versus mavacamten. In real-world practice, provided that the phase 3 trials of aficamten go as expected, as providers, which one or ones would we choose, and why or why not?
Go ahead.
Yeah, I can give you my take on it. I think it's good for us to have choices. Just as we have 2 beta blockers or calcium blockers, I think that there's going to be certain patient populations that may benefit more from one drug versus the other. We still need to see a clear differentiation of the 2 agents and what might be best in one patient population versus the next. What we know so far is that aficamten does have a shorter half-life, so you can titrate it more quickly than you can mavacamten. I think it'll be interesting to see the results on drug-drug interactions. That may be another potential differentiator. But you can imagine, the times that we've seen in the long-term extension and then so far in the real world with mavacamten, where people may drop their ejection fraction, is in the setting of an intercurrent illness. And that's the situation, rapid AFib, significant pneumonia, where you can imagine the patient needs their contractility a bit more. This may happen in their future. That may be someone who you want on a drug with a shorter half-life. On the other hand, if you have a 20-year-old who's going to skip their pills here and there, but is very low likely to have a significant, septic event, et cetera, for half-life. So I think that, in my opinion, it's better to have choices.
Yeah, no, I agree. And I think the one point that Dr. Owens made earlier, the interactions in particular, and this relates maybe more to mavacamten, is that these are often over-the-counter drugs. And you do need to carefully survey for very commonly used medications, in particular omeprazole, drugs that you don't always ask your patients if they're getting over-the-counter Prilosec. So I think as we think about making choices between the two, one is going to be how drug-drug interactions are going to impact the safety of the two, but I completely agree that it's important to have choices.
Thank you. Your comments or recommendations on management of symptomatic but technically non-obstructive versus almost sub-obstructive HCM.
So I think the question was how to clinically manage symptomatic, non-obstructive, and almost obstructive hypertrophic cardiomyopathy. I'll take the second first. So almost obstructive, I think we want to really know that it's not just obstructive. And I think we all have case examples and experience with patients who on their first 1, 2, maybe even 3 echoes didn't quite have an obstructive gradient, but clinically had a story that fits with obstructive HCM. And so what I do for those patients is make sure I get an exercise echo. I make sure that at rest I get a good quality Valsalva maneuver, and sometimes we'll use a postprandial echo in that context. And have been a little humbled by the number of times I told a patient you don't have obstructive HCM and they're still symptomatic, and then really kept testing and picked it up. I have not used pharmacologic provocation in that patient population, so have not used dobutamine or isopril to try to bring it on, but I think that's a somewhat controversial area. And then the last is, do those patients go to the cath lab looking for an invasive diagnosis? And that's not something I've typically used. I've tried to recreate day-to-day life a little bit more, which we can do with echo. For non-obstructive HCM, it's a tough patient population. So we diurese them if they're congested. We try a beta blocker. We try a calcium channel blocker. I think we appreciate that none of these have offered the degree of clinical symptom relief that we want to see in practice. And then we risk stratify. Is this a patient where we're trying our best with medical therapy, but they may need something bigger like cardiac replacement?
I agree completely. Great. Any last questions?
We have a couple questions online, and maybe I'll pose these to Dr. Owens. The first two kind of go together. So in a patient with a family history of hypertrophic cardiomyopathy, they have a normal echo. Would you do genetic testing? And then the sibling question is, how does one do genetic testing for confirmation? Where specifically can blood be sent, and what is specifically ordered?
Okay, great. So the first question, what we like to do in families is draw out that multi-generation pedigree or family history and identify the patient in the family who is, number one, affected with HCM. So we need phenotypic evidence of disease, meaning your echo shows hypertrophy, you clinically have the condition. And then we look to see how many of those individuals there are. And if there are multiple individuals, we would go to the patient who had the youngest age of diagnosis or the most severe phenotype. And that's the individual that we target to start the genetic testing. So we want to start sequencing the DNA in a patient who we know has HCM. And then, depending on the results of that testing, if we're able to identify a pathogenic or disease-causing variant, then we use that information to risk stratify unaffected family members, because we know once we identify that marker in the DNA, as Dr. Lakdawala said, it's autosomal dominant in most cases. It's a 50-50 chance that that variant is passed on to family members, first-degree relatives, and beyond. And so then we would offer testing for the specific pathogenic variant in the unaffected family member who has a normal echo. And that tells us whether they're at risk to develop the disease at some point in life if they're genotype positive, or they're not at risk to develop the disease if they're genotype negative. And that, of course, hinges on the fact that we think that's the one and only cause of HCM in the family. And I've talked for so long, I forgot the second question.
Well, you covered the
I
second
answered
question.
it good.
Yeah.
Okay.
Yeah.
Great.
Do we have time for one more? I think so.
Yes.
So this is a question I think we covered a little last year as a community. So what specific therapies can be considered prior to the onset of heart failure in a patient who has hypertrophic cardiomyopathy? And so this question really, I think, is about disease modification. Do we have any therapies that can prevent people who are at early stages of hypertrophic cardiomyopathy from going on to develop more advanced either remodeling and or symptoms? And the best data that we have comes from the VANISH study. So the VANISH study was a trial of valsartan versus placebo in patients with early hypertrophic cardiomyopathy, and early was defined by a couple different metrics: the absence of severe obstruction, the magnitude of hypertrophy. And using a multi-domain primary outcome, valsartan did improve or reduce progression of disease compared to placebo. That was a phase 2 study, and not something that will be taken up, I think, in the guidelines and perhaps will be fodder for future therapies. And Dr. Owens, are there any lifestyle measures which have impact on hypertrophic cardiomyopathy? So any non-pharmacological therapies that have been studied?
Yes, certainly. So in symptomatic obstructive HCM, we usually start by asking the patient how much they take in each day in terms of hydration. And having a nice, full, preloaded left ventricle is good for obstruction, so we generally recommend that our patients drink at least 64 ounces of non-caffeinated beverages per day. They can add their caffeine in as well. We usually recommend that they do a nice warm-up and a cool-down surrounding aerobic activity, and that they keep their intensity level in a moderate range. And again, if patients wish to undertake more intense exercise, then we have a shared decision-making conversation with them. But we do recommend AHA-based guidelines for activity. We want our patients to remain active. We don't think it's good for anyone to become very sedentary. They become obese, hypertensive, and get all kinds of comorbid conditions that we know. So we do want them to remain active, but to do it safely.
Yeah.
Anything else you would add to
No,
that?
I mean, I completely agree. We know from NHANES data that our HCM patients often become too sedentary. And our colleague, Dr. Saberi and Dr. Wheeler, Dr. Day studied a structured exercise program in people with hypertrophic cardiomyopathy. So this was the RESET trial. And of course, not double-blinded, but randomized, and there was an improvement in functional capacity and some measures of quality of life in patients who were randomized to a structured exercise program, and it was safe within the confines of a modest study size and not a profound amount of exercise. Looks like we have one more question.
What about the super athlete with pretty significant concentric LVH? How do you separate that person from someone who may have underlying hypertrophic myopathy?
Takes some time and effort. So I would say we certainly start with what I would say is a deep phenotyping. So that includes a CPET study, in many cases an MRI, so that we can really look at the morphology of the ventricle, see if there's any signs of scar, delayed enhancement. Look to see that the patient really is as fit as they say they are. Sometimes you put them on a peak VO2 and they say, I'm very, very athletic, but their peak VO2 doesn't reflect that objectively. So I think, number one, you try to make those that fork in the road by morphology, looking to see that diastolic function is supranormal, looking to see that the cavity size is big and not small. All of those things can help us to differentiate physiologic hypertrophy due to remodeling from fitness versus pathologic hypertrophy. But in some cases, it can be confusing, and at times we've had patients sort of detrain for a bit, a period of 16 weeks or so, and see if any of that hypertrophy regresses. Not many athletes that are super athletes really want to go down that path, but occasionally, you could offer that. Dr. Lakdawala, any other thoughts?
No, same deep phenotyping, and I think as a community, we are also more open to shared decision-making. So I think when you reach that point, if things are still ambiguous, conversations can ensue, but I think we need to convey that there is an increased degree of risk. But although not mentioned in our slides today, we look forward to Dr. Lampert's study today, the LIVE-HCM study, which really examines arrhythmic outcomes in people with hypertrophic cardiomyopathy. It's a large study of nearly 1,000 patients that I think will inform those conversations in the future.
You will not get them to stop exercising.
Yeah.
Yeah, I've done it for a handful of people who wanted to go on and do professional sports.
Yeah.
And so it was worth it for them to do a small period to show that it was reversible hypertrophy, and then off to the races they went.
Yeah.
But again, I think now it's less likely that you need to do that. Yeah. Great.
Thank you, everyone.
Thanks so much. Take care.